Hi, it's Dr. Centeno, and thanks so much for joining us today on You've Got the Power. Today we've got a super interesting topic that's going to take a little bit more time, but it's so critical to helping patients recover from craniocervical instability. And that is that right now, for instance, I'll get asked a question a lot on this show. Well, I've got CCI. What kind of injection do I need? And my response is always pretty much the same, right? My response is, well, I don't know what kind of CCI you have, which then maps to what kind of injection you would need to get the best results of recovery. And the biggest problem is that no one's really put together a type of CCI naming convention. And it's a little bit like talking to an oncologist or a cancer doctor about something like a patient walks in and says, I have cancer. What kind of chemotherapy do I need? And the cancer doctor is going to look at you very strangely and say, well, what kind of cancer do you have? There's 500 different kinds of cancer. And each one of those maps to a treatment to get the best results. So that's kind of what we've been doing on here is we've been, I've been getting that kind of thing. I've got CCI. What kind of treatment do I need? Or we've been trying to use surgical definitions of CCI and have that map to injection-based treatment. And one of the things I've learned as being one of the world's pioneers in orthobiologics, meaning, we were doing orthopedic stem cell procedures before anyone even knew they existed back in 2005, is that we need to hone in on this stuff. We've got to be able to make sure that everyone understands that they've got X type of CCI, and that maps to treating these specific ligaments. So we're going to do that today. I'm going to take a little bit longer to get through a presentation, but I think it's going to be worth it in the end. It's a presentation I've spent quite some time on, probably 10, 12 hours on since Friday. So let's get to that, and then I'll take questions. As usual, you can ask questions about this. You can ask questions about lots of things. So let me go ahead and share my screen, and we'll get started on this presentation. Okay, so today's presentation is a classification of what I call subfailure CCI. So subfailure CCI means that there's a ligament stretch injury. We don't have the hangman's fracture or the need for emergency surgery. And no one's ever put together a classification schema before. So I'm going to call this the Centeno classification, since I'm the first person to coalesce all this stuff together. And then we're going to talk about various types of procedures that would be needed in each type of CCI. So let's start jumping into this information. Again, as I always say, if you're interested in getting evaluated to see if you have CCI and you're a candidate for injection-based treatment, I recommend that you don't go through our call center or try to fill out a form on the Centeno-Schultz or Regenix websites. I recommend that you just go directly to Carla, my assistant. And a lot of that is just because both of those places, the Regenix call center, the Centeno-Schultz call center, deal with lots of different kinds of issues, ankles, shoulders, backs, knees, etc. And they're not really set up to deal with the unique types of imaging and other things that CCI patients have. So we find that if you fill out a form on the website, or if you call one of the call centers or send an email to them, it's more likely to get lost, or at least, chewed up in the bureaucracy than it is for someone to get moving forward. So again, send an email to Carla Salas. So patients often believe that CCI is one diagnosis, right? Happens all the time on here. Hey, I've got CCI, what should I do? But the problem is there's many, many different subtypes of CCI. And we have to look at which ligaments are damaged in order to try to figure out how best to help the patient. And this is all customized to the patient. No two patients are alike. Now, there might be similarities between some patients, but each patient walks in with his or her own presentation. And sometimes we need to treat the facet joint. Sometimes we don't. Sometimes we're treating this ligament or that ligament. Sometimes we're treating this nerve or that nerve. Hence, I often see patients who really don't understand not only the kind of CCI they have, but they don't understand the vast differences between posterior and anterior injections and which patient might need which one. And so that costs a lot of resources on their side. I often see patients walk in who have spent $10,000, $20,000 on types of care that if you looked at the ligaments that were injured, were very unlikely to help them. And sometimes they're tapped. Sometimes they have no more money to spend, and that puts them in a really bad situation. You know, I want to talk a little bit about a story from my youth. I was a kid growing up middle class in South Florida, and there was something called the swap shop. If you live in South Florida, maybe it's still there. I don't know. But basically, the swap shop was a big open air market where you could go and buy really cheap stuff. And so we would go to the swap shop as middle class kids when we were older, and we'd spend $20 on a fake Rolex. Now, we knew we were buying a fake Rolex. We didn't think we were getting a Rolex for $20. And it wouldn't last real long, a month or two. You know, the gold plating would start to rub off if it was even gold at all. But, you know, it served its purpose, right? And one of the problems that I see many, many times is that patients don't understand these procedure levels. So they're often buying a fake Rolex, what we used to call a Schmolex. They're paying really top dollar for that. So it's a little bit like they're going to a jewelry store, they're buying a Rolex for $10,000. They're walking out with their Rolex. It breaks. They send it back into Rolex, and Rolex says, that's not a Rolex, that's a fake. So in order to make sure you know what you're getting, we're going to have to dig deep today to have you understand the differences between these procedures. So these are some of the references that went in today's presentation. So let's get into CCI types. What are the different kinds of CCI, and why should we care, and why is this critical for you to understand? So I've kind of broken this down into, in medicine, you know, you often see this thing, type 1, type 2, type 3. I've made it pretty simple here. Type 1 CCI is going to involve C0, C1. So you can see the 1 here. So if you hear type 1, you can always now say that I'm talking about C0, C1. Type 2 is going to involve C1, C2. So you can see that there. So if I talk about type 2, you know, we're talking about C1, C2. Type 3 is similarly about C2, C3. Now, you can have more than one type. We see patients all the time, for instance, with translation at C2-3 plus lateral overhang. And you can obviously have a mild amount of instability, moderate, or severe. So let's start with type 1A. So again, we're talking about type 1. So that maps to C0, C1. And in this case, we're going to be looking at the angle of the skull, or the clivo-axial angle. And that is when someone bends forward, their skull tends to rotate too far, or in neutral, they've got a very low clivo-axial angle. All that means is their skull is rotated forward. Now, the lax ligaments are going to be back here. So those are pretty easy to reach with a very simple ligament injection focused on the nuchal ligaments. Maybe you need a little more. Maybe you need to also get the posterior atlanto-occipital membrane, which is also back there. that takes some higher level stuff, but many patients getting a simple posterior injection will do well here. Now, some patients would also need to get that 0-1 facet treated. And you notice here I'm talking about level 1 procedure, level 3 procedure. We'll get into all of that. But obviously, if you need that facet joint treated, you're not going to get that in a simple prolotherapy injection. They're not capable of doing that very complex procedure in a simple prolo clinic. Now we get into 1B. We're just talking about the opposite. Now the clivo-axial angle, it increases in extension. But now we've got a bit bigger problem here because number one is we often see the skull hit the back of C1 on a DMX here. And that's a problem that I know a lot of patients have. We also see a ballooning out or a buckling there of the dura. In addition to that, the lax ligaments are now in front. So you can inject back here all you want until the cows come home, meaning a posterior injection, but you're nowhere near the ligaments that are causing problems. So now we're talking about a PICL procedure in order to get the ligaments that have problems. And then finally, at this C0, C1 level, there is another type here. This was talked about in one of the references that I put up front. But in addition to that, I've also done a whole video on this concept. And that is normally, so if this is the skull at C0 and this is C1, we see a deep set ball and socket type arrangement here. And as you might imagine, that occipital condyle of C0 sitting in C1, if it's deep, provides stability. But some patients have this very shallow type C0 or occipital condyle sitting at a very shallow C1. And obviously, you don't have that same stability on the left here. So basically, you get instability. Now, not when the ligaments are working, but if the ligaments get stretched and you have this kind of thing, you can see sliding of the skull forward or backward with flexion or extension. And there's a way to figure this out. It's actually, this is how you figure out how deep all of that is here. And that maps to being abnormal if it's below this 0.17 or normal if it's above 0.2. But long story short is this is now a different kind of instability. So we need now to look at which ligaments are allowing this to happen. Obviously, if it's shifting posterior, then we're looking at anterior ligaments. If it's shifting anterior, we're looking at posterior ligaments. So again, trying to match the procedure to the problem. Now we're down to C1, C2. And this is one that we see an opening of the atlantodental interspace. We see an increased grab oaks or dynamic BDI, same concept. But the idea is that C1 is shifting forward, and the lax ligament is the transverse ligament back here that normally binds C1 to C2. So this is, remember, C2 here. This is C1 up front. This is C1 up front. So now there also can be lax ligaments in the posterior. So sometimes when patients get posterior injections with this problem, they'll get a little bit of relief. But that transverse ligament is the strongest ligament in the human body. So if it's stretched, it's unlikely that these lax ligaments are going to be strong enough. So that's more of that PICL procedure from the front to get that transverse ligament. So again, matching what's wrong with the patient to the treatment. And then we get into type 2B, this side-to-side atlantoaxial instability or overhang that we talk about a lot. And the lax ligament is going to be the alar transverse ligament here. And in our clinical experience, You can try to inject the C1, C2 joint. You can try to inject the facet capsules at C1, C2, but it's very unlikely to move the needle on this. That only works about 1 in 5 times in our experience. So that means you have to get that alar accessory ligament injected directly, and that's more that PICL, i.e. a posterior injection is very unlikely to work here. In fact, most of the relief people are getting with posterior injections, if they're reporting that, are probably due to getting some of the stuff into the pissed off C1, C2 joint, which makes them feel better for a while, but it doesn't change the instability picture. So the joint just gets pissed off again. Now we're down to C2-3. So remember when I said type 3 maps to C2-3. And so if you are in flexion here, the lax ligaments are back here. So this means that C2 is shifting forward on C3. Now, this is one where you can do posterior injections all day long and it works really well. So if all you've got is a little bit of instability and flexion at C2-3 causing your symptoms, then this is something that will respond to very inexpensive and very low-tech posterior injections in the supraspinous, interspinous ligaments at C2-3. But you now go the other way. Now we're talking about 3B. So the problem now is an extension. Remember, all the A's are in flexion, all the B's are in extension. Now relaxed ligaments are in the front. This is the anterior longitudinal ligament here. So now you need what I call a type 4 injection. Much, much harder to do. No prolotherapist in the country is going to be able to do this kind of injection, or at least safely, because you've got to use ultrasound and x-ray guidance from the front. You can, again, inject all you want posteriorly, but it's not going to do anything. It's not going to move the needle because the problem ligament is in the front, the anterior longitudinal ligament. And then obviously you can have a 3C where you've got problems in flexion and extension. And again, you need anterior and posterior injections. So I also discuss these structural and treatment modifiers. This is part of customizing treatment. So that is, you can have all of these with a Chiari 1 or 0, which is not causing the problem. It's just making the problem worse if you have instability. You can have cervical medullary syndrome where the dens is pressing on the upper spinal cord and brainstem. You can have HEDS, stretchy ligaments, which is making all of this worse. You can have a pannus, which is really a pissed off and scarred down dens bursa, posterior dens bursa, which then puts more pressure on the spinal cord. You can have a bursal effusion without a big pannus, and that's these bursa that we've talked about that are in front of and back of the dens. You can have a facet effusion. I pick this up all the time on MRI. This is 0-1 facet effusion, and it just gives us more information that that facet joint is getting beat up and it's swollen. You can have facet osteoarthritis. So here, this is C2-3. This is the size of this facet joint, but look at the size of this humongous facet joint there. This one is arthritic, and this one is normal. So, and then you can have internal jugular vein compression, which is more sometimes an innocent bystander, right? It's happening because of the instability. So we still need to fix the instability as the primary cause rather than trying to cut the styloid, because if we cut the styloid as the primary solution, then we're going to get anterior instability on top of craniocervical instability. You can have scoliosis. We've talked about how that puts a rotational moment up top. So that's not helping things. So at some point you might need to treat that. And you can have adjacent segment disease. Someone can fuse your lower neck, which is going to put more pressure on the upper neck, which is going to make all this worse and harder to treat. And then finally, you can have central sensitization. And all central sensitization means is that your nerves are on fire, and it makes all of this harder to treat. And then segmental muscle atrophy on MRI, we've talked about that, how to identify it, etc. That just means that the muscles that stabilize the bowling ball on the stick are weak. So all of these can alter the course of treatment, tell us things we need to treat in addition to treating the main ligaments. And then this is just some naming conventions for all of this that you guys don't necessarily need to focus on. And then you can have, obviously, lots of different symptoms. You can have two patients that have the same type of CCI but present differently. So you've got some people presenting with headaches and lightheaded dizziness. Other people have none of that. They just have some cognitive issues and fatigue and maybe problems with muscle spasms. So that's also important because that tells us a little bit about which one of those modifiers might be causing issues, right? If it comes in on the headache side, we're probably talking about those upper neck joints or nerves up in here. If we've got cognitive issues, that may have nothing to do with those facet joints, but the bad information coming from them. Or if we've got visual issues, I think we've talked about that already. That could be due to the bad proprioceptive information or the superior cervical sympathetic ganglion. And then obviously these are just some 3-letter codes I've given to symptoms from a research standpoint. And again, we can now apply symptoms and those same naming conventions. So we're going to end this up talking about CCI injection procedure types, because this is really important stuff. Again, we see this all the time. Patients who are getting procedures that are very unlikely to help them because they're not thinking about what kind of CCI they have, nor have they really been told that by the doctor. So here's how I have graded these. Obviously, we've got these blind procedures that I don't recommend anybody get in the year 2023. It just makes no sense. Ultrasound imaging is cheap. Obviously, fluoroscopy is more expensive, but at the very least, use an ultrasound machine. So then we've got this level 1 procedure here, 1 star, and this is not stars and how good they are, just so that you can see all the different things that can be injected at different levels. So that's just going to be simple posterior ligaments and then putting the needle on the posterior column. You're not trying to inject any of the facet joints. You're just trying to inject in that general vicinity of where the facet joints live. Then we've got a level 2 procedure where you can add in now very specific injection of those facet joints that are confirmed via fluoroscopy with contrast. Then we get to a level 3 procedure where you add in those upper cervical facet joints that few people inject. Even experienced interventionalists haven't done many 0-1 facet joints, for example. And then we get to a level 4 procedure where we're adding in now things like the anterior and longitudinal ligament and going deep at that posterior glenooccipital membrane. And then a level 5 procedure where we're adding all of the anterior stuff, PICL, etc. So now we're getting at all of these harder to inject things that are in the front or super hard to inject in the back. So obviously, if you've got a simple posterior procedure, but you've got an anterior problem, not going to help you very much. Or if you've got a bad 0-1 facet that has arthritis and it's complaining, and we get rid of the instability with a level 1 or 2 procedure, but no one actually ever injects that facet, you're still going to have symptoms because the symptoms are being generated by that facet. And no one that does a level 1 or 2 procedure is capable of injecting that facet. So now you get some idea of what that looks like. And then these are all the different levels of procedures. Obviously, we've got simple ones being relatively cheap, and we've got complex ones as they go up in levels of complexity, getting more expensive because they require more equipment, et cetera, and more expertise. So again, I'll end here, and we're now going to take some questions. Just to, again, reiterate, if you're interested in getting a telemedicine, please don't go through and call the general clinic line at CSC. Please don't call the Regenix call center or fill out a form on either website. Just contact Carla directly. So in conclusion, there are subtypes of CCI. There are specific injection procedures that match each of these subtypes, and that's an incredibly important thing to understand. So let me get rid of all of those. And I will go to see if we have questions. Looks like we have some questions. So let's see, Ulysses. Ulysses, that comment gets to a bigger problem that we see all the time, which is, why don't traditional doctors, why haven't they bit into this topic? They haven't been into this topic because we don't have even naming conventions as to what this is. So the basic level of getting your average family doctor or orthopedic surgeon to say, yeah, that's a problem, I don't know what to do about it, I'll send you to this guy who does. We have to get to things like naming conventions, which is also important in having patients understand what it is they need or don't need. Regenix, can the density or damage of ligaments be seen when injected under fluoroscopy? Yes, in fact, both injection under fluoroscopy and ultrasound shows us how strong the ligament is or isn't. So for instance, in a strong ligament or tendon, when you inject on either one, the injection slowly moves through the very tight fibers. But when the ligament is really damaged, you'll see it flow very quickly through because there are many small tears within that structure. Fatchen, if someone does provocative maneuvers with the neck, can the inflammation generated make the ligaments thicker for some time? Not quite sure, Fatchen, what you're referencing there. So if you could, I'm not sure if you're on live or not. Maybe if not, just send me an email about that one with a little more information. Pia, do you provide other Regenix facilities treatment protocols in which ligaments should be considered injected in different subtypes? No, this is not something that Regenix clinics are capable of addressing or dealing with on a day-to-day basis. This is a very, very specific patient subtype that requires very, very specific kinds of care that are it's just not going to be there. So no, the answer is the only place you can get treated, evaluated for this stuff that knows which end is up is out in Colorado. Regenix, Robert Long, I won't be on live. Most of what I feel is at the base of the occiput, maybe PAOM, sliding cornflake crunch sound. If I lay flat on the floor, or they slowly lift up, I hear it, or even tense my neck muscles. But does that mean it's posterior? If it's happening when you're going from lying flat into flexion, then that would mean, just based on what you're describing, again, I don't know your imaging, or won't discuss that, obviously, online here. That would indicate more of an anterior problem than a posterior problem, right? Because it may be, if we're just going to stick with 0-1 for a second, that your condyles are not very deep and your skull is sliding backwards in that situation, which would be the anterior ligaments. Remember, it's always the ligament opposite the direction of movement. Other than side to side, that's a whole other story. But we're talking flexion extension. Ulysses, can you use the ultrasound to see maybe ALL damage, ligaments in the neck for evaluation? It's a good question, Ulysses. The answer is the best way to see that is not really what ligaments look like. It's how they function. And that's that flexion extension. Those are flexion extension x-rays or the DMX that we often talk about. So while I might see that the ligament doesn't look great in one specific spot, it's not hard to see on ultrasound from the front. And here we're talking, I believe, about the anterior longitudinal ligament, or ALL. It's not going to tell me how that ligament functions, which is really the key, more than how it looks. Damien, good afternoon, Dr. Centeno. The swap shop is still here in South Florida. Good to hear. I have no idea if it's still there or not. I have fond memories of the swap shop growing up. What are your indications for shockwave therapy? Have you noticed tissue regeneration? Do you perform it? Yeah, no, we wouldn't use shockwave therapy for anything we're talking about here. Shockwave therapy, as I think I've said before, would be good if we were trying to maybe treat superficial issues like up against the skull base, where you have tendons that can get pissed off, or tendinopathy. But for treating these deep ligaments, we would need to have so much shockwave so close to the spinal cord that if we ramped up the power that much, we'd be damaging the spinal cord at the same time. So not going to really apply to what we're talking about here. Now, there's a shockwave machine in the clinic that they'll use for some of those superficial things, but not spinal issues like this. Yeah, so Verse, if we're talking about craniocervical instability, that's only treated in Colorado, not the UK. If we're talking about just a back condition, and maybe that's what you had written here, BECK for back, then I'd recommend algo cells in London. Diana, Mason classification system, sliding of skull back and forward. For some reason, McConnell's are not shallow. What else could cause such sliding skull sensations? I've got posteriors with you due to posterior injury, and we'll get PICL hopefully soon because of AAI. Yeah, so then, Diana, it doesn't have to be that the condyles are shallow. It just has to be that the ligaments are loose enough to allow that. Now, obviously, if you've got deep set condyles, then there's going to be more resistance to motion or sliding motion on the skull at C1. Having said that, if there's enough ligament instability, it's still going to move. So all the condyles do is add gasoline to the bonfire, if you will. Pia. Oh, yeah. Thanks, Pia. Again, this is so important that we all get on the same page about what it is we all have so we can map that to the right kind of treatment. Verse, serious neck issues, and I have to crack my neck every day in order to relieve muscle spasm associated pain. Verse, if you're in London, I think I'd start with the algo cells crew. They're highly trained interventional spine physicians. They generally don't treat the high upper cervical spine, but it sounds like yours may be just more routine mid to lower cervical issues, and that would be a good place to start. Dan, I have so many types. Will DMX cause injury to alar ligaments or that are trying to heal? Shouldn't. Phil, great information. Thank you. Thanks, Phil. Diana, with someone with a high grab oaks overhang, posterior ligament and capsule injury, and who got posterior PRP, what subtle changes and improvements might one notice, aka will be obviously if PRP helped. So again, if there is overhang, posterior is not going to be a definitive treatment. It may be where we start for all sorts of reasons, but it's not going to be a definitive treatment for people with C1, C2 overhang or that type 2B treatment that we looked at. Now, you might get some relief, for instance, of treating the upper cervical facet. So if those upper cervical facets were injected with PRP, then that might give you some relief, and you'd expect to see that relief within 3 to 6 weeks. Let's see, can the chiropractor fix C2-3 instability backwards? They can certainly put it back in place, but we're not going to heal that anterior longitudinal ligament. So in general, that wouldn't work. Deanna, have you ever turned away a PICL because their past was too large? We've certainly turned away PICL patients where they've had too much direct compression, where the amount was epic, meaning large amounts of compression And the good news is that only happens 0.5% of the time where we see that kind of really, really severe compression happening. As far as pannus being too large, it would be something like what I showed, which is not something I've ever even seen clinically to date. None of my patients have a pannus as big as the one I showed you a picture of. That's from a rheumatoid arthritis patient. Isabella, which of these types of instability diagnosed with flexion extension and lateral bend x-rays? Well, if we're talking about routine flexion extension, then the type 3s and the type 2A. So 2A is going to be that increase in grab oaks or increase in atlantodental interspace. And the 3s are going to be the C2-3, either anterolisthesis moving forward or retrolisthesis translating backwards. As far as the lateral bending, if it's an open mouth, we may see the 2B, which is where we have the C1, C2 overhang. Anya, is it possible to inject anterior longitudinal ligament from the front and C2, C7 levels and thoracic spine, or only in the upper neck? No, it can be injected all throughout. Just realize it's a level 4 procedure. So that means that there's a lot that can go wrong, and it takes a highly skilled practitioner. And what I mean by highly skilled is that's probably 1% or less of the interventional spine physicians that are out there, and only 1 in 100 of those would ever have injected this structure before, or even less than that, probably 1 in 1,000. So not something you go to your average prolotherapy clinic and get injected. And you got to be really careful because there's so much up here that's important. You've got the phrenic nerve that drives your breathing. You've got the vagus nerve that drives your heart. You've got the internal and external carotid arteries that give blood to your brain. So damaging any one of those structures while you're getting to the ALL is a really bad day for everybody. So not something you would do unless you really, really know that A, you need to do it to help the person, and B, you got to put it in someone's hands who's done that lots of times before. Lissy, how about the muscle spasm stabilize the neck, especially in the upper facet joints where the ligament laxity is? Definitely something that happens for sure, more in a response to that instability for the most part. Pia, is it your experience you can have muscle spasm in your hamstrings from CCI? Not usually. I think what happens more likely there, or more commonly, is that the chronic neck issues cause the lumbar stabilizers to go offline. As they go offline, then you start to get irritation of the S1 low back nerve, and then the hamstrings kick in. So that's probably a downstream effect of having issues in the upper neck. Ulysses, do you think muscle spasms give me CCI patients headaches? They can definitely give headaches because remember, all those little nerves up here, like the occipital nerve, swiggle either through or around all those upper cervical muscles. So if they get into spasm, they piss off those nerves and you get headaches. Diana, why do some people respond better dextrose prolo below C2 compared to PRP in the same area? Yeah, I would say that that's not most people. I would say just maybe that's a small number of people. I can say that, for instance, if in some EDS patients, depending on their genetic collagen defect, we can see them respond, like my niece, for instance, she responds really well to Prolo and BMC. PRP has never been her thing. Now, that's not how most people respond. She's got a rare collagen deficit. She's had her full genome sequence because she was a junior professor at Cambridge, and one of the perks of the job. So we know exactly what kind of collagen her body doesn't produce. But I would say that most people, again, it's bone marrow concentrate works better than PRP, works better than Prolo, but that doesn't mean we don't have people with genetic defects that are specific in collagen production where they don't line up that way. Isabella, can I take Oxalis? No. Yeah, so any of the benzodiazepines, and that would be one of them, wouldn't be a great thing to take because they're addictive, right? We don't want to take addictive things to try to get to sleep. So that wouldn't be a great strategy. Isabella, do you advise to wear a cervical collar after treatment with PRP? I think I read somewhere that PRP makes ligaments weaker first, but they get stronger. No. A cervical collar is a two-edged sword. You're making muscles weak, and that's why we wouldn't recommend you wear it. Now, having said that, if you're dependent on it, then you would just continue to do what you would normally do, and we would try to wean you out of it as time goes on. But we wouldn't want routinely someone to be in a cervical collar because remember, again, half of stability is muscles and half of stability is ligaments. So it might help your ligaments heal a little bit, but then it make your muscles weaker and you're more unstable. So that's not a good thing. Basil, are patients with healed endodontal fractures still candidates for the PICL? Could be. A lot of that would depend on how it healed. So if it healed in a particularly bad way, then maybe not. But for the most part, yes, they would be still candidates. Diana, will you be posting this system somewhere officially so you can cite you and share with others? Yeah, so this video, now what I'm going to start doing is all telemedicines will get that classification. And I've got a whole presentation that I'll go over with all telemedicine patients where we'll classify them. And then we'll look at everything we talked about and then try to point them towards a procedure that will be effective for their kind of problem, whether that's done with us or someone else, i.e. someone else. If it's a simple posterior prolo, then I'm going to tell the patient, you can come out here, but you don't really need to. You can stay locally and get a simple posterior prolo, and that'll probably help. If it doesn't, we're happy to see you. So it'll be in this video, which will be on YouTube in my live. So if you go to my channel and you look under lives, it'll be there, and you can, I think, give someone a sharing link from there, or it'll be on Facebook and live on Facebook. And then it'll be part of every single evaluation I do. Now, I may, given that you're asking this, just do a separate video without the Q&A and post that as well so people can reference to it a little bit easier. And so they don't have to watch, obviously, an hour-long presentation. So that's another option too. Let me think about that one, Diana. Isabella, for posterior injections, do you use a combination of PRP and PPP? And can you explain the reason for using these different types and different ligaments and joints? Is there dextrose in there as well? So if you're injecting into a joint, like a facet joint, a higher dose platelet-rich plasma will work. If we're injecting into a muscle, then the existing limited data shows that platelet-poor plasma might be more helpful to a muscle. And if you're injecting into a ligament, we'll either use PRP in the ligament or a modified type of dextrose prolotherapy where we add platelet growth factors or what's called platelet lysate. Now, we wouldn't want to use dextrose prolotherapy and PRP together because if we use those together in the same spot, that injures the platelets. And the platelets have their own built-in intelligence as to when to release growth factors. So we don't want to add those two together because if we do, we get platelet raisins, meaning we get dehydrated platelets as the water comes out of the platelet to go into the hypertonic dextrose solution. We don't want to damage those platelets because they have their own internal intelligence about which growth factors and exosomes to release when based on what's happening on the ground. So dextrose prolo plus platelets in the same spot equals damaged platelets. So we don't want to do that. Serena, if you have C1-2 that are counter-rotated, with C2 being the biggest issue, is my biggest problem likely the transverse ligament? If so, it sounds like posterior injections won't be very helpful. So C1, C2 chronic rotation can be caused by lots of different things. One of the things it can be caused by is a scoliosis. So there's a rotational motion. But if it's not caused by something from below, like a scoliosis, then the next biggest cause would be a lax alar ligament. The alar ligament, I've got a video on that, helps to stabilize C1, C2 in rotation. If it is the alar ligament, and that would be detected by overhang on a DMX, so that would be that type 2B, then the answer is posterior injections aren't going to do much. You need to get to the alar ligament directly. So, can't say it won't help, because if you get some stuff in the 1-2 joint, it can feel better, right? Because the 1-2 joint's getting beat up. But as far as solving the issue long-term, no, it's not going to do that, because you're not going to be able to get enough change in that rotational moment to make a go of it, or at least to be very unlikely that you would, maybe a 1 in 5 chance. So yeah, posterior injections would probably be a waste of money there if that's what's causing that. Alicia, I have CCI, do a flexion extension injury from whiplash or due to. So I have C1 to C7 with ilano-occipital simulation from fusion of my C1 lateral masses to the occipital condyles. So Alicia, I'd need more information. Do you mean that you've had a congenital fusion, meaning you were born that way? Assimilation would fit with that discussion, or do you mean that you had an upper cervical fusion surgery? So give me more information on that one. Regenix has been advanced by Harry Winston. Thanks, Dr. Centeno. I never knew there were different kinds of CCI, but 7 consultation soon. Yeah, thanks, Harry. Yeah, there are lots of different kinds. And again, these different types are critical in understanding what kind of treatment would work the best. If I have a C1, C2 counter-rotator with the biggest issue being I think I got that one already. Ulysses, I have a question. Why is there some clinics selling stem cells for 1 to 2K for joint issue? Can you explain that? What do you think are giving? And do you think they're giving fake bone marrow? Yeah, I don't know. Ulysses, maybe give me a link I can look at. I can usually look at the website and tell you in minutes what's going on. I do know that if you are talking about a bone marrow concentrate procedure and you don't have $1 million lab like we have to process that stuff, your only option is to buy a kit from somebody. And if you're buying a kit from somebody, those kits are $1,200 to $1,500. So that doesn't fit, right? It's going to cost you $1,500 for the kit, and you're charging $1,000 for the procedure. There's something that isn't right there. Those numbers don't work out. So, but happy to look at a link if you have it. Genix been advanced by Fimona Jives. About how long would I need to plan to stay in the U.S. for this procedure if I need the big one? Meaning, I'm assuming PICL. So if patients are from out of the country, we generally recommend that they come in 1 or 2 days before, and they stay for 2 to 3 days after. So really talking about the whole week there, maybe coming in on a Sunday or Monday, staying through the end of the week, and that is so that we can see you back in clinic if there's any need to. Now, if you need a second procedure and we have a good idea of how you're going to react and everything was pretty smooth, then you can obviously shorten that up quite a bit. Bethany, have you heard of Dr. Cantor in Florida that does an ultrasonic procedure surgery for spinal stenosis as an alternative to disc replacement or fusion? If so, how do you feel about this procedure? Yeah, I wouldn't go and see an interventional spine physician. This is a hot topic in the interventional spine community. And what I mean by that is that we have lots and lots of interventional spine docs who are now throwing their hat into the get rid of disc bulges mini surgery world. And the concern I have is that you would want to find a minimally invasive spine surgeon who is fellowship trained as a spine surgeon and not an interventional pain guy like me, who kind of took a couple courses to try to see if he could remove disc bulges to expand out the reach of the clinic. So if it were me and my sister, mother, friend, I would say find a spine surgeon that does really small surgeries rather than an interventional pain doctor who's trying to throw his hat in the surgery ring. Fossil, can BMC be used to treat minor stable cervical fractures? If you're talking about the Dens fracture, if it's healed, there'd be no reason to put BMC into it. If you're talking about other fractures, the answer is yes, but a lot of it is just risk benefit. Damien, my shockwave therapy question reference to ankle osteoarthritis. I don't think it would work on ankle osteoarthritis. I think you're more likely to see it work in something like a mild ankle ligament sprain, for example. So you can get to the deltoid ligaments, they're pretty superficial. You can get to the lateral ankle ligaments, the ATF, CF, PTF, they're fairly superficial. You're not going to get the inner part of the CF with shockwave because it's too deep and covered by bone, but at least you could get to like an ATF mild injury with that. It's been advanced by Sherry Kopp. I've just been diagnosed for the first time with anemia. That'd be a problem for a PICL procedure. It definitely would be. It certainly limits our treatment options because it's the amount of stuff you have in the bank, so to speak. So if you've got fewer cells there, it limits the amount that we can take. So we often want people to start working on getting that up. Now, we've had people who have come in with anemia before and we've managed it. I think I've only refused one patient who had such severe anemia, meaning I think she was at a 6 hemoglobin, and a normal for the bottom part of a normal for a woman would be around 11, where we had to refuse doing the procedure because it was not safe. But everyone else who's come in with a low hemoglobin, let's say they're a 10 or a 10.5, we've been able to work around that by just reducing what it is we take. But it will limit treatment options versus someone who has a higher hemoglobin hematocrit. Ulysses, can a nuclear chiropractor fix the C0, C1 back to normal if pushing forward? Again, I think nuclear chiropractors and AO are experts in getting this stuff back in alignment and trying to give the ligaments a chance to heal. And sometimes that works, but obviously sometimes it doesn't, in which case, we get called in. Does shockwave really work with ligament healing? I think the data is pretty early on that at this point. I think you can talk to some doctors who would tell you definitely, and other doctors who would say, they don't think so or they don't know. Damien, I got that. So ankle impingement syndrome. So Damien, I need to know more. That's not a diagnosis we recognize, meaning that if your ankle joint is impinging, there's a reason it's impinging. So I would need to know the reason it's impinging. Now, if no one's given you the reason, it sounds like you haven't gotten a thorough enough diagnosis, meaning the ankles don't just impinge. They'll usually impinge, for example, due to instability or substantial tightnesses in one area or another. Phil, roughly speaking, what is the lead time for first contact to receiving PICL treatment, suitable candidates, inclusive imaging already done? Yeah, that's a good question, Phil. That's something, that's a question, Carla. In general, for most patients right now this changes throughout the year, right? We've got busier times of the year. We've got slower times of the year. Right now, as of last week, I think that was shortened up a bit. I suspect that we'll see it get a little bit longer now as I approach going out for 6 weeks and at the end of April, simply because, things kind of get scrunched up there in the schedule. But if you're interested in knowing that, then reach out to Carla. I'm going to put her email here so that you can reach out to her directly and ask her that question, because she would have more information on that than me. And so I just put Carla's information down there. So reach out to her directly on that. PI, C3 down the C3 and down the whole spine. Same kind of treatment needed since only a few structures involved in instability. I'm not quite sure what the question is. So again, if you've got instability in flexion, then that's the posterior ligaments. If you've got instability in extension, that's the anterior ligaments, whether it's at C2-3 or C5-6. And I've only got about 5 minutes before I have to go to another meeting. So I know I got lots of great questions. We got lots of viewers. So I'm going to try to get to as many of these as I can. Vivan, what is the role of palate reflex loss in Eustachian tube spasm, middle ear syndrome, and CCJ? Do we see Eustachian tube spasm? We do in some patients, not a super common complaint, but it can certainly be related to cranial nerve irritation. As far as its role, it's more just a function of cranial nerve irritation because of the instability than it is a cause of CCI. Stacy, I've had a lot of sleep issues that thought were mostly hormonal. My chiropractor adjusted 6-7. Frankly, did not know something he's doing. He's kind of scared because of my friends. Stacy, I don't know much about the relationship between 6-7 and sleep. Laura, I'm patient Dr. Schultz. How can I find out my classification? This is a classification system that I came up with. I'm sure Dr. Schultz will eventually use it. So that's something really to ask him. This information will be shared with Dr. Schultz. Remember, I'm the guy driving the CCI and PICL treatment bus. And Dr. Schultz is one of the only other physicians in our clinic that does the procedure. But this is something I just came up with and I'm sure he'll use. So that's something to reach out to him about. Diana, does posterior P continue helio after 8 weeks? I'll try not to wear my brace in the house. Do you think I need to walk with a brace in order to give them forcing for remodeling and strength? Well, Diana, I should certainly try to wean out of the brace. That's important to do. But remember, we talked about posterior PRP not being all that effective in treating the overhang part. It's been advanced by Cheryl Hines. How long would recovery be from PICL procedure? That could be anywhere from a couple days to a couple weeks to a couple months. Everyone's different, and there's a bell curve. So that bell curve means that most people are in the 3 to 7 day range. We've got people who don't even know they had anything done, and people who get major flare-ups. Now, thankfully, that's on either tail, but it depends on where you fall in all of that. And now, since we're coming up to the very end of my time period, I'm just going to try to take some of the questions I think are more interesting or I've never answered before. Isabella, I've had occipital prolotherapy a couple of times and my tinnitus got much louder. Do you know why this is? Most likely I have cervical instability. Seems like muscles got weaker. I would need to know what it is they injected, why it is they injected those areas, etc. So if your tinnitus is getting louder, it may be that you got a type of posterior treatment that isn't focused at all on the ligaments that are loose if CCI is causing your tinnitus. But again, occipital prolotherapy doesn't tell me which of those levels I'm dealing with. Was it a level 1 procedure, a level 2 procedure, a level 3 procedure, level 4 procedure, a level 5 procedure? Clearly wasn't probably 3, 4, or 5, but what specific structures did they inject? How did they know they actually injected those structures? I have a cervical MRI, brain, neck, and neck CT scan, and static cervical spine x-rays. Do patients normally do a consultation with you before proceeding with a DMX? I'm also wondering if I should do a consultation visit before getting a DMX. Yeah, so a CT scan has about 50 times the radiation exposure of a DMX. CT scan is equivalent to approximately 100 chest x-rays. A DMX, depending on how much is done, what the machine is all about, might be anywhere from one chest x-ray to a couple. So you've already had a lot more radiation exposure. But getting to the answer to your question, we can certainly take a look at what you have without the need to start with a DMX. So if you wanted to start with a telemedicine, we do that all the time. Probably about half of our telemedicines have a DMX available for us to look at. Half of them don't. And there are times we can get to instability without the DMX. So some of those patients never get one. Most of them do. So I'll leave it up to you, but we can definitely do the telemedicine without. Can muscle atrophy cause CCI symptoms or only ligaments that give symptoms? No, muscle atrophy can do it too. We've seen that. Let's see here. Alicia, no surgery. Yeah, Alicia, so I need to see your images to get a better idea of the congenital abnormalities and how that impacts the ligament structure. So we would want an upper cervical MRI to look at the ligament structure to make sure it's normal to start with. PM, my son has scoliosis C17 to the right. We've heard consider his C2 is turned to the left. I'm not so sure that I could make that determination, but certainly that's going to put rotational forces higher up. Dear Chris, do you know about rotational subluxation of the atlas? When the atlas on cone beam, CT1's one side is closer to styloid process than the other. Why it occurs can be barotrauma, what ligaments. So rotational instability of C1 and C2 is going to be controlled by the alar ligaments. And then I think I'm going to have to jump off here in a second here, guys. I'm trying to get to ones I haven't answered or seen before. Carla, what level does algo cells? So really the level 3 procedures are ones that algo cells can do. Now, it was my understanding that they weren't going to be injecting 0-1 and 1-2 any longer, but there may be some controversy there. So either level 2 or level 3. Pia, that all really depends on how much anemia is present there. And I'm trying again to get to Katrina. Chiari is part of one of those qualifiers. Again, Chiari by itself, if it's a 0 or 1, isn't a problem. It's Chiari plus instability that's the problem. Meaning lots of people are walking around with the Chiari 0s, lots of people are walking with the Chiari 1s, and they have no symptoms. They don't get symptoms, the current theory is, until they get instability plus the Chiari. Kimberly, I remember one talking about certain mouthpieces. You have PICL, it's concerned if you have a small mouth. We haven't really run into that very often. We have lots of different sizes of mouthpieces. And we even have an option to use completely different models. So there's 3 different models that we use. And so if we run into any issues, we just switch to one of the different models that we've created. Amity Rehab Services do lower cervical facet injection with steroids do more harm than good for CCI patients. I wouldn't recommend lower cervical facet injection with steroids. I think that's going to be more likely to harm the patient than help the patient in the long run because those steroids kill off cartilage. We know that pretty conclusively now, both from clinical studies and we've known it for decades in vitro and in vivo studies. Isabella was not in the ligaments. Yeah, so it's never going to help your instability then, Isabella. Okay. Guys, thank you so much. I apologize. I have to cut it short here at 2:05 my time. We've gone about an hour and 5 minutes. I just have a follow-on meeting. So as we talked about today, different types of CCI relate to different kinds of ligaments that are injured, relates to different types of treatments. Obviously, you want to treat the injured ligament, and you first got to find out what kind of CCI you have to figure out what kind of ligaments need to be treated. So thanks so much for watching. I will be here this Friday, so we'll talk about another topic on Friday. And I appreciate all your great questions. I mean, questions are the heart of this show because, we want people to learn, and the only way people learn is by asking questions. So thanks for your great questions, and you all have a great week.